Hello everyone, I'm Urologist Erdem Akkaya. Today I want to inform you about your prostate health during testosterone therapy. Is your prostate gland enlarging? Is it becoming cancerous? Are your complaints of difficulty urinating, which we call prostatism, increasing? Of course, testosterone usually makes the prostate gland grow from the age of 40 to 50. Prostate enlargement, known as BPH, is a disease that includes a number of complaints such as difficulty urinating, frequent urination, intermittent urination, waiting to urinate, and getting up at night to urinate. At the same time, prostate cancer is the most common cancer in men. It can be said that the probability of prostate enlargement or prostate problems in a man who lives long enough is 70%. Do these complaints occur when we receive testosterone therapy in such cases? One of the world's authoritative opinions in urology is that testosterone does not cause prostate cancer. So why was there a fear for years that it might cause prostate cancer? It's because in 1943, when testosterone was removed from the body, a quieter clinical course, improvement. A reduction in prostate volume in prostate cancer patients and shrinkage of the prostate in patients with BPH was noted. The urologist who discovered this was awarded a Nobel Science Prize. Since then, the association between testosterone and prostate cancer has been consistently poorly interpreted. Until the 2000s, it was stated that testosterone does not actually make prostate cancer more aggressive, but that the presence of testosterone in prostate cancer is important. In other words, when testosterone is present in the body in prostate cancer, the prostate cancer grows faster. When testosterone is removed from the body, it can be said that the growth of prostate cancer slows down temporarily. When we administer testosterone externally, the prostate also grows to some extent, but this growth stops after a while. So, in summary, there is no connection between prostate cancer and testosterone. So what is the connection between prostate enlargement and testosterone? Well, when we administer testosterone externally, there is some growth in volume. It grows by 10 to 20% for 3 to 6 months. After a certain time, if we administer 2 or 3 times the testosterone, the prostate volume stops growing. Or, it does not cause an increase in PSH values after a certain amount in the blood test, which is very important for us in the prostate cancer screening test. This was also brought forward by a urologist in 2016 with a theory called androgen saturation of prostate tissue. The theory is that prostate tissue is sensitive to a certain amount of androgens and will not respond to androgens above a certain level. This is a very logical theory. If we look at it, athletes who do all bodybuilding sports would have to have a large prostate, and would all have to have prostate problems. But such a situation has not yet occurred. That is the case with the androgen saturation theory. In the third case, is testosterone treatment given to patients who have complaints of difficulty urinating, frequent urination, interrupted urination, waiting to urinate, or getting up at night to urinate, which we call prostatism. Again, we were very hesitant about this. Because when we give testosterone to patients with these complaints, they get worse. We thought that patients would have discomfort and constipation because of the enlargement of the prostate. But now the guidelines from the Lower Urology Association say that this testosterone treatment can be given in close contact with the patient in a controlled way to patients with a total score below 19, which is a high score. It even says that these complaints can improve. The theory is as follows: by taking testosterone, the organs in the pelvic area, bladder, prostate, scrotum and hip, are supposed to be able to work better due to increased blood flow and nitric oxide. The exact reason for this is, of course, unclear. However, close contact should be made with these patients. In particular, there are studies showing a relationship between testosterone and nocturnal urination. When we increase patients' testosterone, nighttime sleep improves, urine becomes more concentrated, and the hormone desmopressin from the brain, which decreases nighttime urine production, has been shown to increase. This may be beneficial for patients who urinate a lot at night. Waking up at night to urinate is one of the first signs of kidney failure and diabetes. This is because waking up at night to urinate is a sign of deterioration in urine quality and excessive nighttime urine production. But it is not always kidney failure or diabetes. As we age, nighttime waking to urinate increases more and more. As I said, if these patients have a testosterone deficiency, they may benefit. Of course, there are studies that say the opposite, so patients need to stay in close contact. So how is the prostate monitored in urology? For early diagnosis of prostate cancer, it is very important to do the PSH test once a year from the age of 45 if there is a family history of prostate cancer, 48 otherwise once a year from the age of 50, and to perform a rectal examination with a finger. PSA monitoring is very important. If the PSA level is elevated, a more detailed examination, which we call prostate biopsy and prostate MRI, should be performed if necessary. In patients with progressive symptoms, we use a group of medications called alpha blockers, which contain agents such as alfuzosin and tamsulosin. When we administer these medications, the areas that help patients urinate, which we call the bladder neck, relax and the patient can urinate comfortably. These are not medications that provide permanent treatment, just like blood pressure and diabetes medications that patients have to take for years. There are also herbal treatments. They have also been used for years in patients with mild or moderate symptoms. For example, saw palmetto, lycopene, nettle and pumpkin seed extracts have been used for years. The herbal product we call saw palmetto has also found its way into the guidelines of the European Urological Association. It is said that it can be recommended for patients with mild to moderate urinary and prostate symptoms if they do not want side effects related to sexuality. I usually recommend an herbal brand called Sawprost. If the patient does not benefit from this, prostate surgery is the last option for the patient. These are the last options in patients. That's the way it is in general. I would also like to say that you have to be careful about cold medications, especially in patients with prostate problems. In particular, pseudoephedrine-containing drugs such as Nurofen, Afrin, Catarin, and Theraflu. In patients with urinary symptoms associated with BPH, medications used for colds and to relieve nasal congestion unfortunately occlude the urinary tract. The patient may suddenly become obstructed and need to have a catheter placed. These are medications that are very commonly given in primary care centers, namely health centers and emergency rooms. And I have seen every year for years that patients come to us in the winter time because of these medications and have a catheter placed. I have to say this as a warning. Patients with BPH and prostate problems should be wary of these medications. At the same time, some of the medications used for COPD can exacerbate these symptoms. In general, the relationship between prostate and testosterone is like this. Thank you very much for listening and best regards.